Doctor, now we are streaming on Facebook Live.
Okay.
By sharp 3 o'clock, we can begin the session.
Okay, fine. I think 2-3 minutes are only left.
Hello. Dr. Shyambhavi, now we can begin the session.
Okay, fine. So, a very good afternoon to everyone who's becoming a part of the session. So today we'll be talking about something that is known as endoperio lesions. Now, endoperio lesions are basically a combination of both endodontic lesion and a periodontal lesion. So generally these lesions, they usually become a dreaded lesion when it comes to clinical practice, because it is most often than not, it is always very difficult to diagnose whether a lesion is purely endodontic or purely periodontal or a combination of both. So in today's session, we'll just be discussing about the different types of endoperio lesions, the presentations, the diagnosis, and the various treatment options that are available or can be used to treat a frank endoperio lesion. So to begin with, we'll begin with the introduction. Now, the interrelationship between endodontic and periodontal diseases is a subject of speculation, confusion, and controversy for many years, since it involves two different schools of dentistry, that is endodontics as well as periodontics. That is why it has always been a case of confusion for almost all the practitioners. Now, pulpal and periodontal problems are responsible for more than 50% of tooth mortality today, and these lesions, they present challenges to the clinician as far as diagnosis and prognosis of the teeth involved are concerned. So not only is it difficult to diagnose an endoperio lesion, it is even more difficult to understand how good a tooth would react after a treatment has been done. So the prognosis also becomes questionable in most of the cases. So now, why is this endoperio lesion termed as an endoperio lesion? Now, what happens is the periodontium, that is the periodontal ligament, and the dental pulp, which forms the endodontic component. Both of these structures, they have common they have common embryological derivation, mostly because the dental pulp and the periodontal ligament both are derived from the cranial neural crest cells, and these neural crest cells, they are basically the mesenchymal and ectodermal derivatives. So in the development during the developmental stages, what happens is that these neural crest cells, they differentiate into the mesenchymal derivatives as well as the ectodermal derivatives. Now the dental tissues, they have a combination of both of these mesenchymal as well as ectodermal derivatives. So the dental pulp and the periodontal ligament, they share a common point of origin, that is the ectomesenchymal derivation from the cranial neural crest cells. So this is basically the reason why whenever a dental pulp gets involved, the infection tends to travel through the dental pulp to the surrounding periodontium or vice versa. Both ways it can happen. Now, the interrelationship between the periodontium and the pulp was first discovered by Simring and Goldberg in the year 1964. And the pulp and periodontium, they have embryonic, anatomic, as well as functional interrelationship. Mostly because they are both derived from the mesenchymal cells, which in later stages of tooth development form the dental papilla and the dental follicle, which are nothing but the precursors of the periodontium and the pulp, the dental pulp. Now, this embryonic development gives rise to anatomical connections which remain throughout the life. So, when an infection occurs in the endodontic cavity or in the pulp, this infection can get transmitted to the periodontium, or when an infection or a periapical lesion develops in the periodontium, it can get transferred to the pulp or the endodontic cavity. Now, for this to happen, whenever there is an intermission of infection between both the types of structures, there is something called as Endo Perio Lesion that is developed, that is involving both the endodontic part of the tooth as well as the periodontal part of the tooth. Now, to define an Endo Perio lesion, now basically there is no set rule or a set definition for Endo Perio lesion, because it has several presentations and it can be seen in various different types. However, an Endo Perio lesion is defined as one which will have either or all of the following features. So it is basically based on the types of features that are involved. So depending upon the clinical presentations or the symptoms that the patient presents with. So basically, first of all, the tooth involved must be pulpless. If it is an endodontic, a primary endodontic lesion, definitely the pulp will get damaged and there will be a necrosis of pulp that will be seen. So that pulp becomes pulpless. There must be destruction of the periodontal attachment apparatus from the gingival sulcus. So if the tooth is not pulpless, then there must be periodontal detachment and damage of the gingival sulcus as well. So that should also be there, or both together can also be there. Or there is defect in the attachment which should be evident on probing. So probing using a normal Williams probe, you can see whether there is a loss of attachment or not, hence understanding whether there is periodontitis or not. And also there can both root canal treatment and periodontal therapy will be required to resolve the entirety of the lesion. So the fourth point is the most important point, and this is the point which is most often than not the discriminating feature. That is, if there is an endoperio lesion, then an endodontic therapy alone will never be able to heal the lesion, and similarly, a periodontal therapy alone will not be able to bring about the entire healing of the lesion. So it will be, most often than not, it will be requirement of both the endodontic therapy along with the periodontal therapy to bring about the healing of the lesion. So the fourth part here, the fourth point is the one that is most important and has to be kept in mind whenever diagnosing a endoperio lesion or treating an endoperio lesion. Now the next thing is, how does this endoperio lesion exactly form? So basically the pathways that are involved in the transmission of the microorganisms from the endodontic cavity to the periodontium or from the periodontium to the endodontic cavity. So there are basically three different types of pathways that can be seen. There are pathways of developmental origin, that is the anatomical pathways, which is something which will be there because of by the virtue of development of the tooth structure, and it is something that cannot be removed or cannot be closed or done away with. So this is something that is always there. That is the pathway of developmental origin. So the pathways that come under this are the apical foramen, which is a part of every tooth, the accessory canals or the lateral canals, the congenital absence of cementum exposing dentinal tubules. Now this can also be present in some cases, or defective developmental grooves which might be seen. For example, if there is a palatogingival groove or some other kind of developmental groove that is there, then there will be a high chance of acquiring endodontic or periodontal lesion in the due course of time. The next pathway is that of pathways of periodontal pathological origin. Now, pathological origin, basically, these are the pathways which are formed because of some pathology which has occurred, and in retrospect, because of the pathology, there has been a communication that has been established, and because of this communication, the microbes will get a passage for frank transmission, and they'll cause a lesion wherever they get a chance to accumulate and bring about the lesion. So pathways of pathological origin include root fracture following trauma. So whenever there's a root fracture that occurs due to trauma, then there will be opening up of the tooth structure to the periodontium. It can be because of idiopathic root resorption, that is internal root resorption or external root resorption, both of which there will be chances of denudation of the tooth structure, and because of which there will be a communication that will be established between the pulp chamber and the underlying or the overlying periodontium, or because of loss of cementum due to external irritants. There can be also pathways of iatrogenic origin, sometimes because of the treatment that has been given or because of over enthusiastic treatment that has been done. There might be pathways which would be created, and these pathways would also lead to Endo Perio lesions. Now, these are basically these can be seen whenever there is exposure of dentinal tubules following root planing. Now, when there is vigorous root planing done in areas where there is less amount of cementum already present, in those cases there will be exposure of dentinal tubules. They can be because of accidental root perforation during endodontic procedures. Whenever we tend to go for overzealous preparation of the root canal without understanding the proper anatomy or the remaining dentine thickness, in those cases there will be accidental lateral root perforations or root fractures which can happen during endodontic procedures, mostly seen in the maxillary premolars, wherein the roots are not as strong and they have good chances of undergoing vertical root fractures during treatments. So because of that also, endodontic or periodontic or endoperio lesion or true combined lesion can occur. Now this is basically an image. In this image, you can see in the first image, there is internal root resorption wherein the pulp chamber has lost its outline, and because of which there is transmission of microorganisms to the underlying periodontium, and because of which there is a periapical lesion that has formed. And there is loss of periodontal attachment apparatus also. If you can see, there is widening of the lamina dura that is present, which can be easily appreciated in the first radiograph. In the second radiograph, which is showing the external root resorption, it can be seen that though there is not that much of a loss of attachment apparatus, but there is, because of external root resorption, the overlying enamel and dentine has been worn off, and there is a frank communication that has been established between the gingival sulcus or the periodontium and the pulp chamber. So because of this also, again, there will be something called as endoperio lesion that will form. In the next image, in the image showing root fracture, it can be seen how there is a fracture line that has been formed due to trauma, and because of which there is loss of attachment apparatus, as can be seen. There is inflammation all around the root surface of the tooth, and because of that, and since there is a frank communication because of fracture, the microorganisms will get freeway space to enter the pulp chamber as well. So there will be a pulp inflammation as well as the periapical and the periodontal inflammation seen together. The fourth image is that of iatrogenic perforation, wherein you can see there is an instrument separation, and in trying to bypass this instrument, the endodontist or the clinician has gone beyond the apex and has perforated the root outline, and because of this, there will be again a fissure or a opening that will be formed, because from where the inflammation or the organisms, the disease-causing organisms, will enter the from the periapex, they'll enter the root canal, or from the root canal they can enter the periapex. Either ways it can go. In this case, since it shows as a case of retreatment, there are more chances that the organisms from the endodontic cavity will enter the periapex and cause periodontal inflammation in due course of time. So these are basically the pathological pathways that can be seen. In the image in the center, we can see the anatomical pathways, which are basically accessory canals, the dentinal tubules, and the apical foramen. Now these three are the pathways which we cannot do anything about. If there is some inflammation that is there, and long-standing chronic inflammation that is there, and it is not treated in the pulp chamber, then there is nothing we can do, and the inflammation will most often than not travel through the apical foramen or the accessory canals or via the dentinal tubules and affect the underlying periodontium. So in this case, so as to prevent the disease from occurring, it is always advisable that if there is a disease or if there is a loss of sensation in the pulp scene, or if there is damage to the pulp scene, it is always advisable to go ahead with the endodontic therapy as soon as possible, so as to not let pulp become necrotic and lead to further inflammation. Now coming over to the etiology of endoperio lesions. Now etiological factors, they are basically the living pathogens or the non-living pathogens. The living pathogens will be basically the bacteria, viruses and the fungi which might be seen causing the endoperio lesions, whereas the non-living pathogens would be something like foreign bodies, wherein an instrument which has perforated can lead to endoperio lesion, or because of some restoration such as amalgam or root canal filling material, cellulose fibers. Sometimes the paper points which we use for drying the canals, they tend to go beyond the apex, and if certain fibers of these cellulose fibers are left beyond in the periapex, then there are chances of these forming the foci of infection, and upon which the microorganisms will act and cause periodontal abscess or periodontal inflammation. So paper points are also to be used with care. Then they can be used because of gingival retraction cord, the periodontal inflammation can occur, or certain bodies such as Rushton Highland bodies or Russell bodies. These are things which can be seen in the periodontal ligament when there is a frank periodontal inflammation seen. Also, apart from the etiological factors, there are certain contributory factors which can also lead to endoperio lesions, such as poor endodontic treatment, coronal leakage, trauma, root resorption, perforations, developmental malformations, or cracked tooth syndrome. Now, these are basically the contributing factors which can lead to endoperio lesions. Now, coming over to the microbial pathogens that are mostly associated, the three most commonly associated microbial pathogens are Eubacterium species, Peptostreptococcus species, and the Fusobacterium species. So basically, apart from the endodontic pathogens which might be seen as the causative organisms, the periodontal pathogens are the ones which are most commonly involved in cases of endoperio lesions. Now, in a study by Moore et al., they showed that most of the species that have been found in infected root canals can also be present in the periodontal pocket. Now, Roof et al. In 2000, they studied the profiles of periodontal pathogens in pulpal and periodontal diseases associated with same tooth, and concluded that periodontal pathogens often accompany endodontic infections. Now, DENTISTRY et al., they have given in a detailed study they did on endoperio lesions, three most commonly isolated microorganisms, that are F. nucleatum, P. micra, and C. sputigena. These are the three microorganisms which play a pivotal role in the formation or the pathogenesis of the endoperio lesions. So these microorganisms are almost always present in any endoperio lesion. Now coming over to the classification of endoperio lesions. Now endoperio lesions were classified into 5 categories by Simon, Glick and Frank, and this classification is basically a classification which classifies the lesions into primary endodontic lesions, wherein there is only involvement of the pulp, or the primary periodontal lesion, wherein there is only the involvement of the periapical or the periodontium that is seen. Secondary periodontal lesion, wherein there is involvement of the endodontic lesion. There is primary endodontic lesion that has formed, and because of the anatomical or pathological pathways that are present in the tooth structure, the infection has gotten transmitted to the underlying periodontium, and there has been secondary periodontitis that has been developed. Or secondary endodontic lesions, wherein there was a presence of a periodontal pocket and there was periodontitis that was seen, but because of these anatomic pathways or because of pathological pathways which we discussed earlier, the microorganisms found a pathway and they went inside and infected the pulp in turn, leading to secondary endodontic lesion being formed. Or it can be something called as combined lesion or true combined lesion, wherein both endodontic and periodontal lesions are seen together. And since the patient has reported at a stage where there is endodontic involvement as well as periodontal involvement seen together, it is not virtually possible to understand which came first and which came second. So in these cases, it is mostly you go ahead with the treatment, whichever the symptomatic treatment is required. So if the patient has come with pain, you go ahead with endodontic therapy followed by periodontal therapy, and then wait for proper time so that the prognosis can be seen or checked. So this is the true combined lesion. This is a diagrammatic representation of how primary endodontic or primary endodontic secondary periodontal or primary periodontal and secondary endodontic lesion or two combined lesions can be seen. Basically, the pathways can be seen here. It can be via the apical foramen, via the furcal canals, which are seen mostly in the molars, posterior teeth, or from the accessory canals or the lateral canals that are seen. In case when there is no other pathology involved. Now coming over to the diagnosis of endoperio lesion. Now this is the most important component of endoperio lesions, the diagnosis, because this is the most challenging part. Treatment, we all know either it has to be endodontic therapy followed by a periodontal therapy, which can again be surgical or non-surgical depending upon the symptoms. But the diagnosis is what forms the most important criteria for understanding endoperio lesions. Now, to understand this, there's a small table that has been proposed. So, first of all, there is examination that is to be done. So, the first you begin with a visual examination. So, in visual examination, whenever there is a primary endodontic lesion seen, there will be soft tissue presence of sinus opening that will be seen. There will be presence of decay in the tooth or a large restoration or fractured restoration of tooth, erosions, abrasions, cracks, discolorations, or a poorly done root canal therapy can be seen. So anything which is involving the occlusal surface or the surface of the tooth will be seen for primary endodontic lesions, wherein there is endodontic involvement seen primarily. In cases where there is primary periodontal involvement, there will be inflamed gingiva, gingival recession around multiple teeth, accumulation of plaque and subgingival calculus around multiple teeth. The teeth would be intact in this case when there is no endodontic involvement, and there will be presence of swelling indicating periodontal abscess and not periapical abscess. In case of primary endodontic and secondary periodontal lesions, there will be plaque that will be formed in the gingival margins. A sinus tract might be present, which will lead to the inflammation of the marginal gingiva, and there will be exudates occurring from there. There might be root perforation, fracture, or misplaced post, or something which would indicate that there is an endodontic therapy that has gone wrong, because of which there is an inflammation that has occurred. Now then, coming over to the primary periodontal and secondary endodontic lesion, there will be presence of plaque, subgingival calculus, swelling around multiple teeth, presence of pus exudate from the sulcus, gingival sulcus, presence of localized or generalized gingival recession, and exposure of root surface might also be seen. Whereas in case of combined lesions, there will be plaque, calculus, periodontitis will be present in varying degrees. You cannot understand, because again, in combined lesions, you can never know which came first. There will be swelling around single or multiple tooth. So again, you don't know whether it was infection of periodontal origin or endodontic origin. So the swelling can be generalized, or it can be occurring only on the diseased tooth or single tooth. There might be presence of pus and exudate seen in a case of combined lesions as well. Then coming over to pain, the next symptom would be pain. So pain in case of primary endodontic lesions, it will definitely be sharp because of the involvement of the neurons in the pulp. It will be sharp. In primary periodontal cases, it will be usually dull aching and kind of pain. It will be sharp only in acute cases. Whenever there is an acute exacerbation, only then you will see a sharp pain. Otherwise, it will be a dull aching pain, which is because of the baroreceptors that are present in the periodontium. In the primary endodontic and secondary perio lesion, again, if there is an acute exacerbation, then there will be sharp shooting pain. Otherwise, there will be dull aching pain in chronic conditions. So if a patient comes to you in severe pain, and you can see that there is loss of lamina dura, there is loss of periodontal attachment apparatus, and a huge restoration in the oral in the cavity of the patient, and the pulp seems to be inflamed, then you can understand that this is an acute exacerbation of something that was primarily an endodontic lesion, formed a secondary periodontal lesion, and remained chronic for a long duration of time. But given the conditions or whatever the patient the conditions in the oral cavity of the patient developed acute exacerbation and has henceforth come for treatment. Now, in case of primary periodontal and secondary endodontic cases, there is usually dull aching pain, sharp only in acute periodontal abscess, and in case of combined lesions, there will be dull aching pain. Only in acute cases would it be severe. So sharp pain is only seen in primary endodontic cases. Rest everything, it will be usually dull aching pain, which might get exacerbated and lead to sharp pain. Palpation, in case of primary endodontic lesions, it will not indicate whether the inflammatory process is endodontic or periodontal in origin, because in primary endodontic lesion, the lesion is well contained inside the tooth cavity or the pulp cavity. So definitely the periodontal probing or palpation would not lead to anything. In case of primary perio, the pain will be there on palpation. In case of primary endodontic and secondary periodontal, again pain on palpation will be seen. Similarly, with the primary periodontal and combined lesions, pain on palpation will be seen, because somehow or the other there is damage to the underlying periodontal structure. So this is how palpation of the tooth structure is done to understand whether there is involvement of the periodontium or not. Coming over to percussion, now in case of primary endodontic cases, there will be tenderness to percussion present. In case of primary periodontal, sensitivity is present because there is, even if there is not involvement of the pulp, the baroreceptors or the proprioceptive fibers that are present in the periodontium, they will get activated upon percussion, and because of which there will be pain on percussion. So tenderness on percussion will be there. In all the other lesions also, tenderness and percussion will be seen depending upon the varying degrees of the disease progress. Now, this is how tenderness to percussion can be checked, and if the patient perceives pain upon being hit by the blunt end of an hand instrument, then you can understand that there is tenderness and percussion. Now coming over to mobility. Now mobility, fractured roots, and in case of primary endodontic lesions, the fractured root and recently traumatized teeth may present with high mobility. Otherwise, if there is no fracture or there is no recent trauma, then mobility in case of primary endodontic lesions is not that common. Primary periodontal lesion, definitely localized to generalized mobility will be there. In case of primary endo and secondary perio lesions also, there will be localized mobility. In case of primary periodontal and secondary endodontic lesions, there will be generalized mobility. And in true combined lesions, again, there can be generalized mobility with high grade mobility, or it can be localized mobility depending upon the degree to which the tooth is involved. Now, this is how the mobility can be checked by using the blunt ends of two hand instruments. Now coming over to pulp vitality. Now pulp vitality usually can be done using cold test or electric pulp testing. So in case of primary endodontic cases, a lingering response might be seen in case of irreversible pulpitis, or there can be no response in case of necrotic or non-vital pulp. In primary periodontal cases, the pulp is vital. Most often it is vital, and the response to testing is positive. In primary endo and secondary periodontal lesions, pulp vitality tests are negative, because again, entire endodontic cavity has been involved in the disease process, and since it has been involved, only then the periodontal attachment has gotten involved. So that definitely pulp will be non-vital in these cases. In primary periodontal and secondary endodontic cases, pulp vitality may be positive in multi-rooted teeth, because there might be one root that is involved in the loss of attachment apparatus, and the other root might show positivity. So then again, leading to false positive, but then again there will be positivity, but it will be false positive. So again, it is difficult to understand the presence of a primary periodontal and secondary endodontic lesion unless you have gone ahead and made a test cavity and gone ahead with the treatment. So vitality tests cannot be trusted in case of primary periodontal lesions, wherein secondary endodontic involvement is there. Similarly, with true combined lesions, mostly it will be negative, but then again, they can be false positive if there is multi-rooted teeth. So if there is multi-rooted teeth that is present, then it is always advisable to go ahead with the test cavity, remove the decay, and then check for the degree of infection or the disease progress that is present. Then this is the cold testing. Then coming over to pocket probing. In case of primary endodontic lesion, deep, narrow, solitary pocket in the absence of periodontal disease may indicate presence of lesion of endodontic origin or vertical root fracture. In case of primary periodontal lesions, multiple wide and deep pockets will be seen. In primary endodontic and secondary periodontal lesions, presence of solitary wide pocket will be there. But if periodontal lesion is due to a fracture of root, then solitary deep narrow pocket may also be present. In case of primary perio and secondary endo lesions, presence of multiple wide and deep periodontal pockets will be there. And in case of combined lesions, probing reveals the typical conical periodontal type of probing, with the exception that at the base of the periodontal lesion, the probe will abruptly drop further down the lateral root surface and may even extend to the apex of the tooth. So the pocket that is formed will be very deep in case of combined lesions. Coming over to sinus tracing. Now in sinus tracing, a radiograph with gutta-percha points to the apex of the furcation area and the molar in case of primary endodontic lesions, while in primary periodontal lesions, sinus tract mainly at the lateral aspect of the root can be seen. Sinus in case of primary endo and secondary perio, sinus tract mainly at the apex of furcation area, whereas in case of primary perio and secondary endo, again sinus will be the sinus tracing would lead to the GP point pointing towards the lateral aspect of the tooth, whereas in combined lesions it is difficult to trace out the origin of the lesion. If a sinus tract is present, it may be necessary to raise the flap and determine the etiology of the lesion. So just by tracing, you cannot understand whether it was a periodontal lesion or an endodontic lesion. So this is how sinus tracing is done. Radiographs, again, radiographs are the most important part in diagnosing endoperio lesions. In primary periodontal lesion, there will be deep carious lesions, extensive or defective restorations, previously done root canal treatments which are poorly done, possible mishaps, root fractures or root resorption, and with periapical radiolucency can be seen. Primary periodontal lesions, there will be vertical bone loss and more generalized than the lesions of the endodontic origin, and bone loss will be would be wider coronally. In primary endo secondary perio lesions, presence of deep carious lesions, extensive or deep restorations, previously done poor root canal treatment as can be seen in the image, or certain mishaps might be seen. In primary perio and secondary endo, angular bone loss in multiple teeth with wide base coronally and narrow at the apex of the root can be seen. And in combined lesions, the radiographic appearance of combined endodontic periodontal disease may be similar to that of vertically fractured tooth. Cracked tooth testing is also an important thing that is to be done, because cracked tooth syndrome or a cracked tooth form, a fracture that is seen in the cracked tooth might form a pathway for the ingress of the microorganisms. So in case of primary endodontic cases, there will be painful response to the patient at the time of chewing, especially on releasing the biting pressure. In primary periodontal lesions, there will be no symptoms. In case of primary endo secondary perio, painful response to the patient at the time of chewing, especially on releasing the bite. So whenever the bite is released, if there is pain, then it indicates that the pulp is involved. And generally in general periodontal involvement, there might not be such symptoms that are seen. And in case of true combined lesions, painful response to the patient at the time of chewing, especially on releasing the biting pressure. Again, if endodontic involvement is there, so in combined lesion also the same thing will be seen on releasing the biting pressure. So this is how cracked tooth can also be seen by transillumination or using something called as tooth sleuth. It is basically a it is a device to check for the cracked tooth or a cracked tooth syndrome. So this device is placed in between the upper and the lower teeth, and the patient is asked to bite, and depending upon the pain which is perceived at during the biting or upon releasing, the origin of the pain can be determined. Now, another important factor that is to be kept in mind while diagnosing endoperio lesion is to diagnose properly between a periodontal abscess and a periapical abscess. Now, a periodontal abscess will mostly have a vital tooth in its relation, whereas periapical abscess will have a non-vital tooth. Periodontal abscess will not show presence of caries in the tooth, whereas in periapical abscess, there will be 100% caries exposure of the pulp that will be seen. Periodontal abscess, pocket will be present. In periapical abscess, not necessarily presence of pocket will be seen. Periodontal abscess, again, mobility can be seen, whereas in periapical abscess, there will generally not be mobility, but in acute or in chronic cases wherein there has been a periapical abscess for a longer duration of time, definitely minimal mobility might be seen. Periodontal abscess usually gives lateral radiolucency, whereas periapical abscess gives apical radiolucency. Periodontal abscess variable percussion sensitivity, whereas in periapical abscess there is definite sensitivity to percussion. And in periodontal abscess, sinus tracts open via the keratinized gingiva, whereas in periapical abscess, sinus tract opens via alveolar mucosa. So this is how you can differentiate between a periodontal and a periapical abscess, just as to make sure whether the lesion is of endodontic origin or periodontal origin. Now coming over to each and every endodontic lesion in detail. So firstly, we'll start with the primary endodontic lesions and we'll discuss about the various treatment options. So basically in primary endodontic lesions, there is pulpal inflammation that occurs, which is accompanied by an increase in intrapulpal pressure, and because of which there is areas of infarction and coagulation necrosis, which will result in increased intrapulpal pressure. And this increase in intrapulpal pressure will lead to release of toxic agents, which are expressed through patent apical foramen and the lateral and accessory canals, and corresponding lesions in the adjacent periodontium may eventually coalesce and form something called as periapical abscess, extending as a sinus tract into the gingival sulcus upon chronic disease process. So this is basically how a primary endodontic lesion begins, progresses, and then finally leads to opening of a sinus tract. Now coming over to the management of primary endodontic lesions. Now primary endodontic lesions, if there is sinus tract that is present, then and it is important to go ahead with the endodontic management, that is opening up of the root canal, doing a proper biomechanical preparation, cleaning, shaping, proper irrigation, and intracanal medicament placement, which in these cases can be calcium hydroxide, because it has shown to be effective in healing large periapical lesions. So calcium hydroxide can be used as an intracanal medicament, which can be given for a period of 7 days after access opening, cleaning, and shaping. Calcium hydroxide for 7 days can be given, and then the patient can be recalled. Symptoms can be checked, and if there is no symptoms and the canals appear to be dry, then you can go ahead with obturation and the post-endodontic restoration, followed by a full coverage restoration if required. So this is how it goes around with primary endodontic lesion. And since there is no involvement of the periapex or the periodontal lesion, you do not need to go ahead with the periodontal therapy per se, and just a good endodontic therapy with a good follow-up would lead to a good prognosis and long-term healing. Now coming over to primary periodontal lesions, they begin in the sulcus and migrate to the apex. As deposits of plaque and calculus increase the inflammation, they slowly destroy the attachment apparatus. Now these lesions, they infiltrate the lateral canals, accessory canals, or exposed dentinal tubules, but the path of least resistance is the one that is through the sulcular area, that is the gingival sulcus. And the healthy pulp tissue is highly polymerized, highly vascular tissue, and it is most often than not, it is resistant to infection. So it is not always that this primary periodontal lesion will affect the pulp, because pulp is highly vascularized and highly polymerized. So even if these, if there is ingress of microorganisms in moderation, the pulp has the ability to heal from the damage that is done by the periodontal pathogens, and the pulp will remain vital, and hence only a primary periodontal lesion will be seen wherein there is no involvement of the pulp and the pulp remains vital. So this is what happens in primary periodontal lesions, and prognosis is not as favorable as primary endodontic lesions, because again in endodontic lesions it is an enclosed cavity, and if you can clean up this enclosed cavity properly, then you can go achieve a hermetic seal and do away with the microorganisms that are involved. Whereas in cases where there is periodontal involvement, it is not that easy to go ahead with the management. So primary periodontal lesions, they are treated by hygiene phase therapy at first. That is basically scaling and root planing and whatever is required, just the basic hygiene procedure in the periodontal therapy. Subsequently, poor restorations or developmental grooves that are involved in the lesion must be removed. So in case if there is something called as palatogingival groove and you can identify it while doing your initial diagnosis, then those have to be removed or thoroughly cleaned by raising the flap. Otherwise, the periodontal lesion will not heal. Periodontal surgery might also be required, because even if after completion of the hygiene phase, if there is no healing that is seen, then periodontal surgery is the next step that is to be done. And presence of intact cementum, it is important for protection of the pulp and various, and hence vigorous surgical periodontal procedures that remove cementum and exposed dental tubules should be avoided, because you do not want to do more damage while doing the treatment rather than healing. So if you're doing rigorous root planing procedures or surgical procedures, there are chances that the cementum might wear off and the dentinal tubules will again form the anatomical pathways for the microorganisms to go ahead and infect the pulp. So care has to be taken while doing this therapy for primary periodontal lesions. So minimize the use of ultrasonics and rotary scaling instruments should be preferred while treating primary periodontal lesions. Supportive, and then surgical treatment might also be done in case where there is no healing via hygiene phase or via root planing and all is done. So in surgical cases also, the flap is raised, as it can be seen in the first image, and because since there is also bone loss that is there, so the flap is raised, the plaque, tartar, and whatever the calculus is there is removed and cleaned via root planing, and then the bone is also denuded bone is smoothened and the reshaped properly, and then graft, if required, graft can be placed, and then the flap is sutured back, and healing is proper healing is achieved via the suture placement, and the healing by primary intention after the suture removal can be done. Now, in case of primary endo and secondary periodontal lesion, there is basically necrosis of pulp that is seen, and because of which bone resorption and radiolucency can appear at the apex of the tooth and in the furcation along with the root. The lesion can expand to destroy the attachment apparatus of the tooth, leading to periodontitis. Periapical inflammatory lesion, they basically form because highly vascularized granulation tissue will be present, and it will be infiltrated to varying degrees by the inflammatory cells. So the periapical inflammation the cavity will mostly be consisting of granulation tissue, which will have neutrophils and plasma cells and macrophages and lymphocytes in abundance. Now, again, this is just so as to diagnose whether it was just a primary endodontic lesion with secondary periodontal lesion. It is definitely important to go ahead with a histopathological examination, wherein you can find the neutrophils and plasma cells and macrophages and all these the immune cells, inflammatory cells you can find. But otherwise, just to go ahead with clinical symptoms, you just have to see that there is caries exposure, which has led to the necrosis of the pulp, because of which there is periapical inflammation that is formed, and because of which there is periodontitis that has occurred around the inflamed tooth. So it will be a localized inflammation that will be seen in case of primary endodontic and secondary periodontal lesions. So in these cases also, they may also occur as a result of iatrogenic damage, such as root perforation or fracture during root canal treatment or placement of pins in post, or root fractures may also be present as primary endodontic lesions with secondary periodontal involvements. Now, to go ahead with the management, first of all, it has to be treated with endodontic therapy and simple hygiene phase therapy that is required. And endodontic therapy, again, if there is a large periapical abscess that is formed, then there might be multi-visit endodontics that might be required with in between placement of intracanal medicament, which will favor the repair and bring down the inflammation. And the treatment results should be evaluated every 2 to 3 months, and because the healing of the periapical lesion will definitely take at least 3 to 4 months, and it cannot be seen immediately after doing root canal therapy or the hygiene phase therapy. So the patient has to be kept on follow-up, so that's to monitor whether the treatment which has been meted out is helpful or not. Then primary endodontic and secondary perio lesions, they can be occurring because of root perforations also and root fractures also. So in case of root perforations, if there is root perforation, then it should be treated according to the etiology. So if there is perforation that has occurred because of the strip perforation, that is the instrument has gone beyond the apex, or it has perforated the curvature of the root. In these cases, it is important to go ahead with proper cleaning and shaping, and repair material of choice should be placed. A proper irrigation should be done so as to sterilize the area, and then put material which has good sealing ability with a good sealer, so that the obturation stays there for a longer duration of time. In case of root fractures, something called as root resection or hemisection can also be useful, wherein because if in a multi-rooted tooth, one root is damaged and one root shows promise and is properly placed and does not show signs of inflammation, then the infected or the inflamed root can be extracted, as it can be seen in the image, and that root can be removed. And because of it, and the remaining tooth structure can be root canal treated, and a bridge or a crown can be given, so as to form the bring the tooth back into form and function. Root resection can also be done, wherein the mesiobuccal root or the distobuccal root of the maxillary molars can be done, depending upon the type of damage that is there. Mostly distobuccal root of maxillary molars is resected. When there is inflammation that is seen occurring only in the distobuccal root, then that root can be resected, and the remaining tooth can be root canal treated and brought back to form and function. In case of primary endo and secondary perio lesions, there are various non-surgical managements that can also be done, such as decompression technique, wherein tube is placed inside the swelling or the sinus opening that is there. An incision is made, and a tube, as seen in the first image, can be placed from where the exudate or the periapical exudate or the pus can be discharged. And this tube is placed for a couple of days so as to get the entire exudate out. And once the entire exudate is out, the tube can be removed, irrigation can be done, and the incision can be sutured back. There can be non-surgical decompression techniques also that can be done via aspiration through the root canal, wherein a vacuum adapter can be used, wherein aspiration, the vacuum adapter can be placed inside the root canal, and because of the vacuum that is generated in the suction tip, the periapical exudates can be suctioned out from the root canal, and the lesion sterilization can be achieved. And there's something called as apexum procedure as well, wherein there is night eye ablator that is used, and this ablator is attached to a rotary instrument, and it is passed through the root canal to the apex, wherein at the apex the micro ablator tube comes out and it just rotates so that there is disturbance in the periapex that is created, and the microorganisms that have been there and they have achieved they've colonized, they can get disturbed, and because of which the inflammatory reaction of the body starts to get into action, and the action of the body itself leads to the healing of the periapical lesion, and there is the immune response of the body leads to the healing of the lesion. And they can also be, because after the apexum procedure, profuse irrigation can be done so as to get the debris that has been formed because of the rotation of the night eye ablator can be removed, and hence healing can be expected. Now, primary periodontal and secondary endodontic lesion, there is something called as retrograde pulpitis that is seen here, wherein pulpitis occurs via the gingival sulcus. So initially the gingival sulcus and the periodontal ligament gets involved, then the inflammation travels up from the periapex and causes retrograde pulpitis, and hence the pulp gets involved. So basically in these cases, the ability to eliminate the periodontal component of the defect ultimately dictates the treatment of the tooth. If the majority of the bony support has been lost from periodontitis, then there will be hopeless prognosis. Bone support is mandatory to bring ahead some prognosis in these types of lesions. And if the decision to retain the tooth is made, then endodontic therapy should be done before periodontal pocket elimination or any type of periodontal treatment that is given. So endodontic therapy should be done first so that the chances of increasing the inflammation via the endodontic cavity is removed. Once the endodontic cavity is clean, sealed properly, then the periodontal apparatus can be taken into approach, and periodontal therapy can be done so as to eliminate the pocket. So periodontal therapy we might range from scaling to root planing or to surgical treatments as and when required. Again, true combined lesions, there can be three different types of combined lesions. First, wherein the tooth with two separate lesions can be seen. One is endodontic lesion, usually periapical, and one periodontal with no communication. You can that is the first type. Second, teeth with single lesion that involves both endodontal and periodontal pathosis. And third, teeth in which endodontic and periodontal lesions were once separate but now communicate. So this is theoretically, true combined lesions can be divided into three categories, but clinically, however, it is impossible to understand which lesion came first and which came second, and what happened when. It is just a when the patient presents to you, it will definitely be something wherein there will be periodontal loss, periapical abscess, as well as endodontic access, endodontic pulpal damage that will be seen. So everything will be seen together. So treatment, basically primarily endodontic therapy is done, then followed by periodontal involvement. So and periodontal therapy might be palliative periodontal therapy in the form of root planing, scaling, etc., or it can be surgical therapy depending upon the healing of the lesion after the endodontic therapy. So first of all, endodontic therapy is done, the lesion is kept under check, follow-up is done for nearly 3 months, and even after 3 months the healing is not seen or the lesion persists and the patient complains of pain or other symptoms, then periodontal therapy can be taken up, so periodontal therapy in the form of surgical therapy might also be required. Something called as GTR therapy and bone grafting is also done in case of true combined lesions when there is excessive bone loss. So if there is excessive bone loss, the flap can be raised, the bone can be reshaped, and the damage in the area of the damaged bone, the graft can be placed, and a membrane, GTR membrane, can be placed on top of it, so as the new bone generation gets guided to the exact location where it has to grow or where it has to form, and the suture can be placed so that, and then the healing can be anticipated. Something called as splinting can also be done when there is extreme mobility. So in cases of extreme mobility, splinting can also be done so as to bring the teeth back into form and function and to keep them stable so that further damage is prevented. And this is a small case report wherein a true combined lesion was seen, and a 45-year-old woman presented to inquire about the prognosis of or the preserving of tooth number 36, as it can be seen in the image A. It is a poorly done root canal treatment with a full coverage restoration, which has led to furcation bone loss and a periapical abscess, as well as bone loss around the entire tooth structure. Now, the patient's medical status was non-contributory. So the tooth was characterized by gingival reddening and swelling at the buccal side. The patient complained of periodic discharge of pus from the periodontal pocket, sensitivity on percussion, tooth mobility, and intermittent pain. Radiographs displayed a bony defect in the furcal and the periapical area of 3/6, which had unsuccessful root canal treatment. So the probing depth at the furcal area was 12 mm. So the decision was made, first of all, to go ahead with the re-root canal therapy, wherein the coronal restoration was removed and the previously done unsatisfactory root canal treatment was repaired or done again, and a proper root canal therapy was done as seen in image B. And once that was done, a proper post-endodontic restoration was given, and the patient was kept for follow-up of 3 months. Now, after 3 months, when the patient reported, again the periapical lesion had shown some healing, but the focal area still remained unhealed. So the decision was taken to go ahead with the periodontal therapy, wherein periodontal regenerative therapy surgery was performed, and the flap was raised, the focal defect was localized, the cleaning and irrigation of that area was done, graft was placed in, the flap was sutured back, and this is the lesion after the periodontal therapy, and the healing can be seen that not only the periapex but the focal area has also healed. So this is how you go about treating a true combined endoperio lesion. Now, to summarize the therapy, again, whenever there is primary endodontic lesion, endodontic therapy should be performed without much periodontal therapy, just the palliative care. When there is periodontal lesion, primarily periodontal lesion, then only periodontal therapy should be performed, and endodontic aspect should be kept in check, but not necessarily endodontic intervention may not necessarily be required. Whereas in case of combined lesions, when there is primary endodontic lesion, then first the treatment of endodontic therapy and simple hygiene phase of periodontal therapy is done, and then evaluation of 2 to 3 months is done. And if after 2 to 3 months it is understood that periodontal therapy is required, then periodontal therapy is meted out. And if the primary endodontic and secondary periodontal lesion is because of some iatrogenic damage or some fracture or perforation, then sealing of the perforation with a suitable material is to be done, or management of the root fracture is to be done as per the guidelines that are required or the symptoms that are seen. Whereas in case of primary periodontal and secondary endodontic lesion, periodontal therapy is required after endodontic therapy. So initially endodontic therapy is done if required, and then regenerative therapy in the form of GTR membrane, as we discussed earlier, can be done, and re-evaluation is required every 2 to 3 months. And if if periapical resolution occurs after 2 to 3 months, then if there is no mobility, then you can go ahead with follow-up and nothing else is required. Whereas when there is a mobility of tooth which is more than grade 1, then splinting is required. Whereas if there is no periapical resolution, then there is hopeless prognosis, then extraction is required. And if the tooth is a suitable candidate for root resection or hemisection, then root resection or hemisection can be done, followed by the periodontal therapy as required. And follow-up of 3, 6, and 12 months is mandatory to bring about proper treatment, that is to bring about proper treatment of the lesion. So in conclusion, it can be said that an endoperio lesion can have a varied pathogenesis, which ranges from quite simple to relatively complex ones. To make a correct diagnosis, the clinician should have thorough understanding and scientific knowledge of these lesions, and therefore to achieve best outcome of these lesions, a multidisciplinary approach would be involved. A clinician needs to perform restorative, endodontic or periodontal therapy, either singly or in combination, to bring about the proper healing. These were the references, and that is it. In case if anybody has any doubt, they can ask. We're done with the lecture as the topic as it is. It has been covered. If anybody has any doubt, then we can take the questions.
Hi, doctor. This is Sitaram again from Chesa. I hope there is no questions posted in the Facebook though. If there is any questions posted on Facebook, we can also answer them later on.
Should we end the meeting?
Yeah, doctor, we end the meeting.
Am I audible?